Program. We are now ready to begin.
Thanks so much, Leila, and I want to say good afternoon to all of you on the East Coast, and good morning to those of us that are on the West Coast. I'm finally starting to unthaw here in Denver. We've had unseasonably low temperatures, and so we've got the sun out and starting to warm up. Well, let's go ahead and get started. We do have changes that are affecting pain management coming in 2010. I'm going to be periodically mentioning the slide number. It'll be the number in the lower right-hand corner of the slide so that if you need to step away, just listen for that and you can come back in. What we're going to cover today, some in more detail than others, but we're going to look at the top code sets for changes, ICD-9, CPT, HCPCS. We're going to look at the OIG work plan and briefly look at some of the changes in the Federal Register. I have information that's available as through the day, but we know that if anything can change between now and December 31st. Well, for ICD-9 for 2010, we know that our changes became effective October 1st. When HIPAA came into place, we no longer have that grace period, so we've been using our new ICD-9 codes for about little over 2.5 months. That change brought in over 300 new diagnosis codes, and of those, over half were new E-codes that many practices fail to look at and fail to report. And I strongly recommend for those of you that don't report E-codes to go ahead and go look back in that section. The conventions that I've used with these handouts are new codes are identified by a circle, and the revisions are identified by a triangle. That's the common notifications nomenclatures used in many books. We had 45 revised. They were primarily just grammatical or adding clarifying terms. And we had 23 deleted or invalid codes. And for the most part, those were just the ones that were deleted because we went on to expand out to a fourth or fifth digit in those new diagnosis codes. Our first chapter that had codes that might be used in some pain management practice is the endocrine, chapter 3, the endocrine, nutritional, metabolic diseases and immunity disorders. We have the gouty arthropathy expanded to a fifth digit, so we're getting that additional specificity. I've included the definitions of some of the terms that are in those codes, particularly the with and without TOFUS, TOFI. Again, I'm not going to spend tremendous amounts of time here, but for those of you that do have referral sources from podiatry or have referral sources potentially from the bone and foot orthopedic specialist, you may want to take a look at these codes. The next section that we really have anything that's applicable for pain management is back in Chapter 16, our symptoms, signs, and ill-defined conditions. We had an explosion out of the 799 codes for nervousness. The title was actually changed from nervousness to signs and symptoms involving an emotional state. It went from a fourth digit to a fifth digit. These codes specifically exclude anxiety and depression. Those codes would be reported back in with our 300 in the mental illness section. These are, again, signs and symptoms. And if they're inherent, if they're considered an integral part or inherent to an established diagnosis and syndrome, we're not going to separately report these. One of the advantages for this explosion out to the fifth digit for our ICD-9 is these almost word for word match our ICD-10 in the R45 code category for ICD-10. So some of our patients sometimes have some of these signs and symptoms along with their chronic pain. So we'll want to look to these. These may support the medical necessity for some of the prescriptions that our providers write for patients. In Chapter 17, we have a new complications code, the 995.24, failed moderate sedation during a procedure. This could be used as one of the explanations for a procedure that needed to be stopped. We're in the middle of doing a stellate ganglion. Our provider's using moderate sedation, and the patient is just very anxious and will not lay still. And our provider elects to terminate the procedure. And so we could be using this as an additional diagnosis code to help paint that picture. Likewise, if our doctors were to reschedule that and they're asking for anesthesia to be available and provide, for instance, MAC anesthesia, then they would more than likely be able to report the V code, V15.80, that this patient has a personal history of failed moderate sedation. And so we're using those more as explanations for perhaps the medical necessity for having to have an additional separate anesthesia provider that's providing moderate sedation for our pain management services. We had a couple other V codes that may potentially be used, V61.42, substance abuse in the family. That particularly puts our patients at a higher risk for those that are on our Schedule II narcotics. Also, if our providers are doing any of the more invasive, more advanced procedures, occasionally we'll need to have some pre-procedure labs drawn, and we have a V code that we've had an explosion out in that area, so V72.63. And then we start into our E codes, and I'm not going to go over these individually, but look more at the sections. Many of these were at the request of our armed forces. They asked the National Centers for Health Statistics to provide these codes so they can better track the injuries for our armed forces. And so our first section is internal cause of injury for activity status, and it's really to indicate the status of the person at the time. So was the person on military activity? Is the person a civilian activity done for income and pay? This is going to be only a single code per applicable encounter. We would not be reporting more than one of these. The next section is external cause of injury for activity. This is looking at the activity the patient was seeking health care that they had. So if they had a heart attack while shoveling snow that